I am Dr. Rajeev Pachauri from Agra, and practicing otologist, ENT surgeon at Agra. So I would say that is stapedectomy or stapedotomy or stapes surgery is still known as the most skilled surgery of the ENT, and that is true because whenever I do implant, also I do all the surgeries, and whenever I start stapes surgery, I have a little bit raised blood pressure because, and it has never happened with the implant also in any surgery, but step is that's why, and that's why I said it is a surgery of otologist, and they should do it, and we can share a few good points with us. It's still known as the most skilled surgery of the ENT, and besides skill, you need a good case selection, good armamentarium in an operation theater. Armamentarium doesn't mean that you should have perfect all the lasers, everything. You should have all the equipments, modern equipments, and the instrument which you are most comfortable with, like perforator. If you are using drill, then you should have the drill which you are most comfortable. If you're using laser, then I think you should have well knowledge, or we should have a good knowledge about the laser. So there's no second chance in the surgery, and that's why we say that case selection is very important in established cases. And I would say a few cases which I think we should care that patients should have a good health with especially socially unacceptable ABG gap. Theoretically, we said that for best stability, we should have a AB gap of 20, 25, 30 decibel. But depends on the person who is going for the surgery, like what exactly he's, where he is functioning, where he's working, what exactly is social life, what exactly is the professional life. So a socially unacceptable ABG gap for the patient also. It is most important thing. Second is if bilateral release negative is there, then it is the best. These are the best candidates. Very the patient should have a very good discrimination score, so that can give you a perfect post-operative result. And above all, a desire of the surgery. Patients should come to you for the surgery. You have two options. Either you can give hearing aid trial for the patient, and you can give surgical option also. And it is our job. We should give option of both the things. But if patient is willing for the surgery, then we should go for surgery. If he's not accepting, he wants a hearing aid, then we should not compel the patient for the surgery. And that is the main important thing. Few patients are there with, I think we should avoid those cases for a better rate. That we should, in fact, it is a contraindication is that if patient is having only one working ear, we should avoid these cases. Cochlear otosclerosis, both with poor AVG gap, is again are not good candidate because post-operatively they will not have a good discrimination, and so many other complications are there. If patient is having pre-existing vertigo or clinical evidence of 11th and heart drops, tinnitus, and but so many issues are there, then we should avoid, or we should give a proper, uh, you can say, consolation to the patient that you're not the good candidate for the surgery. If foci with positive SWOT sign, if on otoscopy, if you see that it is a typical appearance of the otosclerosed focus, then we should avoid it because these are the active focus. In spite of good surgery, the patient is going to have problem later on. So I think we should start with medical treatment, then we should go for the surgery in future. And or if patient is insisting, then we should explain them well in detail before starting the surgery. These are not the good candidate because if patient is having extensive polyposis, adenoid, or so many other issues are there, Q function is not normal, then I think we should avoid it because in spite of having good surgical outcome, patient would have recurrent attack of the conductive hearing loss, and they would blame your surgery, or they would have some other secondary infection in the ear, and that can damage your surgical outcome. These are not the ideal candidate. And of course, yes, or perforation with otosclerosis, because we can nowadays we are asking the patient to go for the CT scan, because if a patient is having CS perforation, then if you ask for CT scan, we may get an active focus of otosclerosis in that area, and that we can diagnose it, or a small perforation with irrational, or you can say inappropriate AB gap would give suspicion of the otosclerosis. So we never do antiplasty or grafting with stapedectomy single stage. So we should avoid, we should reconstruct the drum, then go for the second stage surgery. These are the cases where we should take precaution while taking this patient for the surgery. a very young patient or very elderly patient. Because very young patient, if patient is less than 12 years, 30 years, we should avoid it, or do a proper workup, because these kids have so many other associated less syndromes could be there. Some cochlear vascular pathology could be there. So they should work up. And I think earliest stage, in my opinion, should be around 13, 14 years. After proper workup, after proper radiological examination and other associated investigation. And in elderly patients, because they are not good candidate, because of they may have a not a good discrimination, and associated illness could be there. So we should take uh, extra precaution while taking these patients for the surgery. These are worst cases. I think revision step is with unknown cause of primary failure. A patient is coming to you, being operated somewhere else, and you don't know. So we should do all the proper investigation before, especially very high end or 0.3 mm cut CT scan, along with the other associated investigation, and then we should give a proper and proper diagnosis, and we should explain the patient regarding the outcome of that. I will explain in detail later on. So these are not a good candidate pregnancy. We should avoid it as much as possible. And second year surgery, if the patient is being operated by you for first year and he's coming to you second year, then there are some of the issues are there. You should check the preoperative or operative finding, whether chorda is intact or not, or because these patients have very high expectation for the other year, and some associated illness also, this associated complications also there. As patient is being operated by someone else, he is coming to you for the other year, then you should check why he has left that primary first surgeon, why he is coming to you, and any other, try to get the primary record. If records are not available, then you have to take the patient for the year. But with all, again, as I mentioned, do all the investigation before taking for the surgery. So these are the cases where we should take precaution. I think it is must in all the step-based cases that you should take informed consent in writing regarding on table. You may have to abandon the surgery, you may have to postpone the surgery, and you have to stop at particular steps. You should tell the patient that it is a blind process. We are opening the middle ear and we are going for the surgery, and at any stage we may have to come out without finishing surgery. That you have to explain the patient in advance to avoid the post-operative or later on complications, or as miss any other things. The total chances of, though it is very rare and it should not be there, but theoretically and practically it is there, the chances of total SN loss may be there, because step is, that's why step is known as high risk surgery, because 0.03% chances of SN loss are there. That you should explain the patient what type of tinnitus and dizziness is known complication for known sequelae of the surgery for 1 or 2 days, but sometimes because of long piston, sometimes because of overcorrections, over manipulation, chances of long lasting vertigo tinnitus could be there. So you should tell the patient that you just suppose if persist for more than 3 to 5 or 7 days, then you may require re-exploration or a long medical treatment. Facial weakness, though it is very uncommon, but you have to tell the patient weakness or paralysis are there. Recurrent conductive deafness, of course, you have to tell the patient, post-operative, these are common findings. Regarding the method and material, method of doing the surgery is very subjective. It is individualistic, and I would say that depends on your training, from your train, your experience, and so many things that depends on you. So, but the material which you are using for the STP surgery is, I think, we should not compromise on any piston. Whatever material you're using, whether you're Teflon, whether you're titanium, but you should be well aware of that the physiology, and you should be well experienced with that particular material, and never compromise on the cost basis. That don't never go for the cheaper one. Those who do not have good memories, etc. So never compromise. That is unacceptable in our STP surgery. This is one thing I think I would recommend, I would request, I would advise that all should go for this. Just see this video, patient being operated, but see this beautiful structure which has been moving after sound stimulation, and that is the try to adapt this or try to preserve this God-gifted protection mechanism with like that is stapedial muscle, and try to there are so many techniques are there try to learn it, try to adapt it, and try to use it in your surgical Stapes surgery without compromising the outcome. That is the main point. Because if you preserve this cauda, this stability tendon, then hyperacusis, you can decrease the hyperacusis, which is the, I think, very common in post-op cases. They just complain that whenever we go to market, we're shopping, then we get a sound, different sound, hyperacusis there. You can prevent it better. You can give better stability to the piston, to the incus, better discrimination score, better tolerance to the higher amplitude sound. These are few points which come problems which patients face in their post-operative period, and better adaptation. Because if patient is having low problem, less problem in first surgery, then they would go for the second year surgery later on without any fear, because of good experience they had in first surgery. So there are so many ways you can protect this. One is a stem. You can, if the luckily that is like there's a bucci is in the anterior part, anterior annulus, then just to break the anterior annulus and take out this bone, and without putting the piston, you can give a you can give a better hearing. So that is one mechanism. One is triple ST, that is Stapes superstructure suspension technique, adapted by Professor Suri, where he just take cutting the upper Stapes superstructure and rotating with the stability and putting on the promontory after putting the piston. That gives suspension, and you can preserve the chordatum and this stapedius muscle. There's many other ways, but try to preserve if you can, and try to learn this technique at different places and anywhere. And when you are doing Stapes surgery, on the table, get ready for these things, and you should prepare yourself like that. You do while elevating the flap, you can damage the perforation, and you can damage the drum, and that you can repair very well. Try to avoid this point, chorda damage. I think this is the point I would like to say, because if you're doing one year, and if you're preserving that, if you're cutting the chorda, then suppose you're going for the other year, then you have to take extra precautions second year. So why to take risk for the other year? So try to preserve this chorda in primary case, give extra time, preserve the blood supply of the chorda, and never try to overstretch it, because it gives unpleasant feeling to the patient for many months. And that better hearing is sometimes been overshadowed by the post-operative chorda complications of syphilis. So try to avoid descending facial, overhang facial nerve is very common. And if it is not obstructing your view, if you can visualize the over window, then go ahead with the surgery. And if the piston is touching the chorda, facial nerve is overpressing on the piston, it doesn't make a big difference in the hearing outcome. And even the facial, if it's in touch contact with the piston, nothing like facial weakness, etc. Perineum flooding is very common. I'm sorry, not very common. And because since we are not doing preoperative radiological examination, we are not doing preoperative CT scan, it happens. But I think that's why a new concept is that try to do CT scan, good quality CT scan in all the cases. So you can demarcate those cases who have congenital or associated cochlear or vestibular pathology, so you can prevent them. Floating or submerged footplate is very, you can say, bad complication on the table. So if it is by chance, if it has happened, then never try to play with the footplate with your hook, etc. Just wait for some time, and if you are able to manage it, then manage. Otherwise, hold the surgery, put some material over there, and come out, and later you can go for the other option for the hearing, etc. And if it is coming up, never, if you are well aware where technique, you have learned this thing, then you can make a hole through the promontory and take out the footplate and put a vein graft and do the surgery. But never try to fiddle with the floating plate once it is inside. Oblative footplate is, I think, there's a sometimes on table we get this footplate, and in this case, never try to make a hole. I will show the video later on. So just use your drill and try to take out extra tissue from there and focus from there and make the footplate glue, and then do your Stapes surgery. Make a hole and put a piston over there. Persistent stapeditis is very uncommon, 0.03% incidence is there. But if it is a big artery, then I think we should hold it and uh, come out and go for the other option of the hearing aids. And if it is a small artery, then you can bipolarize it, and you can go ahead with surgery. If your artery is in the entry half, then you can also do carry on with your foot plates. But never try to cauterize a thick artery, because it can make the things worse on the table. So I think avoid it. Round window otosclerosis, I think we should always look when, like we look for the malleus stapes fixation. We should also check round window otosclerosis, round window also in all the cases. And if it is, then try to take it out on the same setting, and you can go ahead with the stapes surgery with perfect result. Blood in the vestibule, I think it doesn't go, suppose during after making a hole, blood is there, that doesn't go inside, because the perilymph pressure is more than outside pressure. But somehow it has gone inside. Nothing to worry. Give steroid and then do your procedure later on in the same setting. A narrow over window niche, again it depends on a skill, your armamentarium which you have with your hand, whether you're laser or not. So, and if you are comfortable, never try to break that area. Never try to put in a small place. Never try to put make a hole over there, perforation by perforator or drill, because it can damage the facial and other things. So, if you're comfortable, go ahead. Malleus fixity is again a very good thing, because in all the cases we always recommend to check the malar movement, incus movement, uh, and if we find that something is it totally fixes there, then I think it is not the good case. Go for the other option of hearing it, or if possible, you can go for the stapio medio stability, and these are very good result in all the cases. And you can use same piston, Teflon piston. You can have a separate weight piston for this uh, surgery. I think, but a few things which one thing I would like to share. So I will just try to find out that though it is not possible preoperatively, sometimes we can get a congenital stapes fixation, temporal sclerosis, otosclerosis. Otosclerosis, 95% cases. Temporal sclerosis, if you're finding on table that it is temporal sclerosis, then I think to try to remove as much as possible, and foot plate should be well clean out, then go for surgery. Never try to leave any temporal sclerotic focus around the foot plate. Otherwise, it will create problem for you later on, and your patient will come to you for same problem again and again. Congenital stapes fixation is one more that should be diagnosed with the CT scan and operatively, or on table we may get a gusher. Sometimes we may get other problem on the table. So I think we should, all the things we should keep in mind. Post-operative tips, because these are, I think, after surgery, after a smooth surgery, we should keep in mind few points that we should ask the patient never try to stop the sneezing, because it can create problem on table. Now, on post-operative, avoid trauma to head. That is, I think, avoid strain against closed glottis. That is again more thing. Which patient should have a good. We should give laxative, so she should not have constipation over there. Avoid wear trauma for at least for 1 month. That is, I think, it's very subjective. Few people advise flying after 2 weeks. Some people advise flying after 1 month. So again, it depends on the surgical skill of the surgeon and the technique which you are using for the surgery. That is, I think, very important point. Avoid lifting heavy weight and bending forward, because sometimes it can create vertigo and other associated illness. So these few points I would like to share. I would like to share that you should tell the patient in advance. And if any problem after 4, 5, 7 days, person is developed sudden vertigo, tinnitus, or loss of hearing, they should report the surgeon as early as possible, because sometimes piston comes out, perilymph leak is there. So many things are there. I think we should tell the patient and give advice about it. A few videos are there that I would like to share with that. These are very practical videos been taken from my friends. So some are mine videos. Just see this video and just check. Not go blindly, because the surgeon is doing something on a foot plate, and he's trying to make a hole with a perforator. He is doing fine, and you can see wonderful 0.4 or 0.5 perforator he is using. and now hole is well made, and he is ready to put a piston over there, and I'm sure this patient will get a good hearing uh, on second, third, or maybe after 1-2 months. But just see that what is wrong over here. The wrong point is that this foot plate is not fit for this perforation at right on. This is a typical uh, thick foot plate, and I think it should be drilled before making a hole, and it is an operative foot plate. So one point is that making a hole and putting a piston is not a surgery. Just check what exactly you are doing, how thick is the foot plate, and what exactly, where exactly is the focus of the otosclerosis. Then you should try and go for the surgery. And never compromise, as I told earlier, never compromise with the piston. Just see how bad is this piston, and the surgeon is taking it out because of the bending of the while putting the piston, and the bend is there. And even after putting the piston is prepared, the patient will not have a perfect hearing AB gap. He will not get a perfect AB gap in the post-op period. This is very common. I ever lose patients because any experienced or unexperienced surgeon, it can happen with anyone. And the piston by putting piston goes inside. But once it is happened, just wait for 10 seconds, 15 seconds, close your eye, because the surgeon, what surgeon is doing, he is just trying to take it out with the same forceps, and poor patient must be in trouble because he must be getting giddy. Or just wait for 5-10 seconds, take other instrument and take it out, and then put it again in the same position, or take it out and make it a proper length, etc. And this is the ideal, because never try to be in hurry, never try to be in stress at the surgery. Have some patience on the table. I think one thing is like that. If any step surgeon should know this step, and that is this step is because we never know while making hole, while doing surgery, our foot plates comes out, and you may have a floating fluid where you so many complications could be there. And everybody should know how to take a vein graft, how to prepare it, how to put it, where should be intima, where should be external. So the mechanism of taking the graft, perfect graft preparation, and putting on the oval window should be well aware. Everybody should know it, and it is the primary step you should do while learning this step in surgery. Because in whatever experience we have, it can happen with anyone, and you can come out easily if you know how to take a good vein graft. That is the uh, cariomosis for this all the step surgeon. Whosoever is using whatever implant, whatever processes, whatever piston you're using, try to take a good your supportive instrument like knife, etc. Just see this. This surgeon has put a Teflon and titanium piston, but just see a big, you can say, uh, because of improper cutting, and he used the piston for the surgery, and the patient developed vertigo, giddiness of second, third day, and hearing was not bad, but vertigo, giddiness. And he was taken for the re-explosion of 5 or 6 days, and then he found that something was wrong with the piston, and he, after cutting, he put it again, and the patient was perfectly all right. So keep these things in mind on table. Never try to fight. If you have a good quality piston, then no problem. But this surgeon is trying to put the piston after fighting with the incus, and these are the cases where chances of incus dislocations are there, and these are one of the worst conditions a surgeon can have on the table. So try to open the piston very in a proper way, and then put it. One more way is very easy. You can do with your 15 number knife. Cut the two ends on the opening side, and then put the incus long process in the piston. That is one more way you can use in your surgery. Uh, Advice. I think this is very common because most of us are not having most of ENT surgeon otologists do not have a very good measuring rod, and very few companies are providing, because same company rod, same company measuring instrument should be there, but it happens with everyone. So in spite of being best assessed by your measuring instrument. Sometimes you may get a long piston. So in all, I advise, in fact, I do in my case, after putting the piston inside the vestibule, we always check how much is inside. Just zoom it. Just try to, because you have microscope, and then in all the, so just check exactly uh, with different zoom where exactly use piston before making a final close call for the close, and just check, okay, how much your piston is inside the vestibule. And if you're not satisfied, and if it is more than, you feel that is length is more than expected, then try never hitch to replace the piston and take it out and put it again with a proper length. You can cut it. It takes extra 3 to 5 minutes, but you can have better sleep on the same day. And try to seal this area, whatever material you use. The best one is your blood or with a fat around. Uh, though people say that fat and gel foam has a chance of granulosa too, but I think in this case I would recommend that you should seal this area to avoid the perineal leak later on. That is one more advice. This is, I think, very practical point. Never remove attic bone excessively, because it is our habit. We try to get a proper functioning. We try to get a more space in the attic area. But ideally, the best part is just expose the incus up to the body, and never do blind curating in this area, because if you do blind curating, chances of incus dislocation are there. That is again a worst thing. And by chance your incus is dislocated, then I think you have to abandon surgery, wait for 1 or 2 months, reach open it again. If it is getting fixed, then you can go for surgery, but never try to fiddle with the uh, displaced incus in same sitting. So never remove attic bone excessively, because if you take out the bone excessively because of retraction, because of the piston being in touch with the tympanic membrane, you get some lots of granular tissues in that area. And just see the picture, patient developed, and they have a peeping drum because of the discharge, and where patient have beeping, and sometimes we get, just see, there's lots of granular tissues are there, and patient is having this recurrent attack of ear discharge, head and neck headache, sometimes vertigo, and later on they can have bleeding from the area. And these are the cases you have to re-explore and take out the piston, or you have to clean out the you can clean the granular tissues and put a cartilage or a drum over there. But again, it's a why to do it, so it's better to take precautions while doing the surgery. These are few precautions which I would have shared with you. So stapes surgery, I think it's a basic surgery, and I would recommend it should be a basic surgery. It should be in the basic menu of every ENT, every otologic surgeon. They should not have a hitch to start it. Complications rates are there, we know it, but if you take precautions, starting from case selection, your armamentarium, your confidence level, is skill. If you are new, then do step-by surgery under guidance of your seniors, your friends, and the best learning is doing the step-by surgery. You should have your friends on with you, so if any complications do happen, call them. They will correct it. And if you follow all the basic principles, basic ideas, then you will not never give any complications. And if complications are there, you have many ways to correct it. So I think again I would say, go and learn and start this surgery, basic surgery, because it is the most rewarding surgery of the ENT. Thank you very much.